Let's move here to, let's get Brian Mulligan back in and talking about a useful technique that is not a snag, not a mobilization with movement, but as we alluded to earlier, a nag in the cervical spine and what the indications are for that. So,
okay.
I would now like to show you a technique that we call NAGS. I only teach 2 mobilizations on my courses. One's NAGS and one is reverse NAGS. And they are pure mobilizations, not mobilizations with movement. And I have to include these in the program because I think they're unique. Most of the mobs done on the cervical spine, for instance, are done with the patient lying prone. Now, you get a kyphotic patient and you lie them prone on a bed, they're not comfortable.
right.
And the other thing is that, you know, although you might get some relief while they're lying prone, when they get up, you're not sure what you've achieved.
Right.
So the wonderful thing about NAGS is that it's done in weight bearing, so the patient's sitting up. And the indications for these are, one, if you have an elderly person, because an elderly person, their joints are a bit brittle, and you've got to be very careful with the elderly. And this is a very gentle technique. And because it's gentle, it can also be used on an acute, or sorry, a neck that's lost motion in all directions, a pretty sore neck. You know, it hurts to side bend,
Irritable
rotate.
condition, we might
Yes,
say, right.
That's right. And another use for NAGS is a test for irritability.
How about multi-directional instability? You know, the patient that comes in, they can't turn
Oh,
left,
this is
right.
when
You
you
don't
use
know
them.
where to start.
No,
So.
no. And the other thing, because it's multi-directional, and because you're looking for irritability, NAGS are, you could say, it's affecting the facets on both sides. It's a bilateral technique.
Right.
You can use them if you're a skilled, you know, skilled therapist on each side, but let's just concentrate on doing them centrally.
Right.
Now, what do? The patient is seated.
Right.
You stand beside the patient in such a way that if I do any work here, that stabilizes the thoracic spine or the trunk. If I'm here doing some NAGS, they'll move.
Right.
If I'm here, they don't move.
Right.
The head is cradled gently. You don't grip it. And when you're gripping the head, do it just above the jaw, temporomandibular jaw, never under the jaw. That would be horrible. So it's just
Kind of
over
like
the
a porcelain football then.
Yes, yes. Now, I've got the patient's head, when you cradle it to you, you must make sure it's straight.
Right.
It's not twisted, it's not bent too far forward,
Right.
and it's tilted. Now, here we are, we're in position. I am going to grasp around the occiput with 3 of my fingers, index, third and fourth, and the middle phalanx of my little finger will locate on a spinous process. Doesn't matter which one.
Right.
Normally, when you've lost movement in all directions, you do several levels at the same time.
Okay.
So I'm located with the middle phalanx on a spinous process. The Thenar eminence of my other hand is placed on the little finger in such a way that when I push on the little finger, I'm going to push in the direction of the facet plane, the treatment plane. So here's an example of pushing in the correct direction, and it's gentle, and your little finger is relaxed. The head doesn't move.
Right.
It doesn't move at all. It's so gentle. But if you don't push correctly on the little finger, if you cover the little finger so you can't see it, and then try to push in nothing's happening.
Right.
And then you tend to push in and then go forward. And that's very unpleasant.
Right.
So you've got to be right on target, push accurately in the right direction the moment you start.
Brian, when you say traction, it's not like mechanical traction, not a real aggressive traction, right?
No, it's very subtle. Can I turn the chair around so that
Absolutely.
perhaps they can see
A
what's
little better
happening?
for the viewer.
The other way. Just stand up for a moment, please, Ed. And I would like you sitting down there again. Absolutely marvellous. Now, I'm standing as I was before, and my right leg is, of course, level with the middle of his thigh.
Right.
And if I take more weight on my right leg, that's going to give some distraction.
Sure.
But I'm talking about a very gentle.
Very
if you gave a strong traction, you'd never get the facets to move.
Right.
Because you've taken all the movement out.
Right.
So there I am located as I should be on the appropriate spinous process. And you can see from this action the direction towards his eyeball. This does not move. And because I'm standing more on this leg, there's the distraction. And you would go up and down, just gently. Right. One joint after the other.
If you, as you said, if you're a very skilled manual therapist and you wanted to make this very specific to one motion segment, then you could do that.
Of course
right?
you
I mean,
can. You could
don't
come
have
to the side, and once I'm out there, I'm still going to go up from the facet plane on that side. And again, this doesn't move. And just think about it. You mustn't go too far forward. Now all the structures are tight.
Right.
And if you go too far back, the spinous processes have come together and you can't locate. So a little bit of flexion to make them more accessible. Hand position, not covering the finger, which you can probably see on the monitor, but just there. And now I can push up in the right direction. And look how I'm relaxed. As I do it, my shoulders are relaxed. It's just this action.
In your clinical experience, Brian, what levels do you think it's most advantageous to use these techniques?
3, 4, 4, 5, 5, 6. Okay. Yep.
So
you
typically
can
we
do
stay
them
away
down
from
here, but you start falling off.
Right.
And with some people, it depends how kyphotic they are.
Sure.
But once you go down a bit, you start using other techniques. But, it's an invaluable technique in the elderly, and so I think of myself.
Right.
And poor old Ed here. It's invaluable with a very sore neck,
restricted
in all directions. And golly gosh, if that's hurting, you'd be very careful.
So once you've done your nags, hands off, and then you're still looking again at what's happened with the movement, the rotation.
You expect an immediate improvement in range.
Right. I said that.
But patients love it if you are skilled and you do it correctly.
Thank you, Brian. Excellent. Brian, let's go ahead and look at reverse nags a little more in depth and have you demonstrate on a subject.
It's my pleasure. And so this is how you would do it with a real patient.
So are you trying to stabilize the upper segments above where you're treating?
Yes, well, when you say stabilize, not necessarily. All I'm doing here is stabilizing the patient, if you like, so that if I do any work here, they're not going to fly around. So I'm against the patient, and I'm just holding their head. Now, it could be that you might have to, with some people, hold the opposite shoulder. But you'll see why when we apply the technique. There is the hand position, as you've shown us, and you've got to find exactly where those transverse processes are. And the only way to do so is initially to push ventrally. And when you push ventrally, you will probably locate, if you just go up and down like my finger is, you'll suddenly find, hello, I'm in a little valley. Now, if you come out of that valley, you've got to go over the transverse process. You go over and into the next valley, and over and into the next valley. But once you're in that valley and you're located under the transverse process, you've now got a bony contact. So when you move it, I've got a bony contact there, right there. If I keep that pressure in, keep that contact, I can now start doing a reverse nag. So let me just try it here on it. I've got to find it first. I've got it there, and I've got it there. Now, I've got a bony contact. I lower my arm, and I'm just going to come straight up. Now, it's not a gross movement, because you can't move it that much, but it's a difficult movement. And I tend, when teaching, to make it a unilateral movement, because people usually have a restriction on one side only. The head won't go right round, so that would be the side to which you work. So you can use then your index finger, like you did, or you can use your thumb, say on this side, and some people can't use this bilateral technique because their thumbs are hypermobile. And I would think 1 out of 3 people, their thumbs are useless. And short of a transplant, it just won't work. And they have to, in fact, use their index finger on one side, then on the other. But once they've located, they come straight up. Now, the indications, as you said, are for in-range rotation, and if you have a stiff flick spine, you can't get elevation anyway. If I slump my spine, I can't get my arm up. So this area is important when dealing with shoulders, and it's important even when dealing with necks. Because once you get to this point, rotation is now taking place here.
Absolutely. And that's actually been shown in a recent article in Spine magazine, that you move your arm, you move your thoracic spine as well. So.
Yes, yeah. Now there we are, I'm up here. Can you feel that on there? I'll use my thumb just for something different. Oops, I slipped. Now I'm on it. and I'm moving.
If I come back to that question I gave you about stabilization, if you saw a lot of movement in the head, then you could certainly stabilize the head as well, right, as you're doing the reverse nag, and not worry about moving someone's neck too much.
Now, I'm glad you raised that issue, because this is rather difficult, and you need, a bit of effort. And people, because they're using effort here, tend to rest on the head. And the consequences are headaches and a cervical disturbance.
Right.
And in the land of litigation, you don't do things like that. So you can hold the head, but don't lean on it, even if it's your mate. Now, that is
and there's only a small amount of motion in each one of these. If you get a little bit of movement above and below, it's all right.
I'm just going to ask you, Ed, if you can notice the difference when I'm doing it correctly or incorrectly, and you're not a therapist, so you can be completely honest. Now, there I am. It's on the bone.
Yeah,
That's just soft tissue.
you're moving all around there.
Yeah, just moving all around there.
For the purpose, Brian, of making sure we're not going to confuse the viewer, a reverse nag is not an MWM.
No.
Right.
No. In my book, there are two techniques dealt with that are not MWMs.
Right.
One is called a nag, and the other is called a reverse nag. These are mobilizations applied to the cervical and upper thoracic spine. And the only reason I include them is that they're done, as you've already pointed out, when the patient is weight-bearing and sitting. You get a person down on their tummy and their head's like in this position, and you mobilize the neck. When they get up, it's not successful.
Right.
And some people can't lie like that unless they have nasal problems.
Right.
But these techniques are in sitting, and if you get a result in sitting, you keep it. If you get a result in lying, you don't always keep it.
A good technique as well for treating those modern technology. We're all in front of computers and our poor posture. They got the poor neck. You meet some of those people at cocktail parties.
Can you just put your chin forward? All of it. These chins here. Yeah. The head is jutting forward. And they get problems here. This is horrible. And you've got to loosen that area up. But
one other little pearl that you dropped there, I want to make sure the viewer remembers, is that you talked about if it's unilateral pain, then you typically go to the side of where the pain is?
Yes.
Okay?
Yes, this is usually 99 out of 100. I can't ever remember doing a reverse nag on the left side to get right rotation. And on courses, I will look at a room full of people and say, has anyone lost end range rotation? I will bring them out and I'll say, before I even start, I will change this.
Right.
And I do.
So that basically proves the point that end range cervical rotation also involves the thoracic spine. So if you don't treat the thoracic spine, you may not get end range shoulder motion, you may not get end range cervical range motion, you may not be able to get someone's posture.